Welcome to the Urgent Care Association's Solutions on Demand webinar brought to you by HealthTrackRx. Today we will discuss the role of rapid multiplex PCR to optimize clinical decision-making when evaluating infectious disease complaints in the outpatient setting, and really focused on the heat of the summer. Change the diagnostic challenges that you'll see in your clinic during these summertime months. And to work through these cases, we're joined by two experts in molecular infectious disease diagnostics and urgent care medicine. I'm your moderator, Ben Favre. We start off with Dr. Janie French, who is a microbiologist and medical science liaison for HealthTrackRx. Janie, how you doing? And tell me your thoughts on these cases.
I'm excited to be here today. We decided to use these cases today because the pathogens that cause infections in the summer change. They're going to be different than what clinicians may be used to seeing with respiratory infections that have a more well-known seasonality. And some of these infections cause particular diagnostic challenges. So I'm excited to talk about some of the reasons we see different infections in the summer and how clinicians may want to think about diagnostics when patients like these present in their clinics.
Great stuff. Thank you, Janie. We're also honored to have Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville, most importantly, but he's also the Chief Medical Officer for HealthTrackRx. Stephen, what are your thoughts from a clinical perspective on these cases that we see during the summer?
Well, Ben, hello. Great to work with you today, and also my colleague, Janie French. Very excited about these cases. These are some of the ones that I have found most challenging in clinical practice over several decades. I was in the clinic yesterday, and summer is a different environment. Yet infectious disease are prominent problems that we in the urgent care confront. The profile is different. We'll look forward to sharing some of those examples today and look forward to input from our audience.
And with that, let's jump into our first case. So Dr. Goldberg, we start off with a case, the 70-year-old patient into your clinic, wants to just get checked out, denies any subjective complaints. He says he has a new relationship, and he also has a long-standing primary care physician. No relevant medical history other than that. Dr. Goldberg, what are your thoughts when someone comes in and has a case like this?
Well, Ben, a lot that informs our approach is what's said and what's not said. So what's first interesting is that this person has an established primary care relationship and is choosing not to go that route for this problem. That's noteworthy. Also, we're all reading that sexually transmitted disease events in those above 65 are becoming more frequent. This person's in a new relationship and very well might be experiencing symptoms they've never had before. They could be confusing, they could be embarrassing. So those features could make the evaluation a bit more difficult.
Janie, what jumps out at you about this presentation?
Yeah, so I think there's a few things. As Dr. Goldberg said, STIs pose an important public health challenge. Early diagnosis and treatment is critical to prevent their onward transmission. However, it's also important to understand risk in a case like this, especially if they're simply requesting to get checked out without any subjective complaints. Because we all want to be good antibiotic stewards and avoid unnecessary antibiotics if it's not actually indicated.
Very interesting. Thank you. So Dr. Goldberg, on clinical exam, no positive findings, and in the laboratory, no point of care test available. So what's your next step here?
Well, Ben, first I'll note it's great to have a microbiologist help us think through these cases. It really helps broaden your understanding of the environment and considerations as you're evaluating an individual patient. So that's great for today. What I would say is the findings of nothing on exam aren't remarkable and is quite common. And in the urgent care center, usually the only point of care testing that might be relevant to this problem could be a urine dipstick. And it likely wouldn't offer some insights for this particular person's complaint. So securing a collection for a multiplex PCR evaluation that could come the next day could give some precise information that could inform our diagnosis and treatment. And then the practitioner needs to make a decision based on the history, exam. Do you use empiric treatment or do you wait for more specific diagnostic insights?
You mentioned we have a microbiologist here. With that, Janie, walk us through from a microbiology perspective, what's the pathogens we need to be concerned about, and how are you thinking about this from a microbiology perspective?
If the patient has no subjective complaints and the exam is unremarkable, providing antibiotics immediately in the clinic might not be necessary and could drive potential overtreatment. However, there are some other microbiologic factors that we may want to consider. As Dr. Goldberg mentioned, STI complaints in patients over 65 have risen over the past decade. For example, in the United States, rates of gonorrhea have gone from 1.5 to 5.9 cases per 100,000. So almost quadrupling in the past decade. We also know that there are increased rates of STI visits in the summer months, as shown in this figure from the Journal of Urgent Care Medicine. We know that this patient may be at risk for an STI, but there's a few additional things to consider based on their sexual history and what information you can glean from them. Maybe you want to consider also looking at HIV or syphilis testing. So then what actual diagnostic techniques are available to you? Well, culture is not commonly used for sexually transmitted infections because they're difficult to grow in culture, and PCR is typically considered the standard of care. Beyond that, they may consider RPR if they're interested in testing for syphilis as well. I want to take a second here to talk more about PCR because this will be important throughout the talk. What is rapid clinically actionable PCR?
So Janie, to get into that, post-COVID, everybody knows what PCR is, but how is rapid clinically actionable PCR different than what people know as just regular PCR testing?
So there's a few different flavors of PCR, both in, is it testing for a single target? Are you testing for a very large panel of targets? How is it reading out? Is it just a qualitative result that it's detected or not detected? Or is it quantitative? Is there some sort of microbial load interpretation there? We need to talk more specifically about rapid clinically actionable PCR, which is based on this IDSA public policy paper called Better Test, Better Care, Improved Diagnostics for Infectious Diseases. In this, they outlined 5 criteria to improve ID diagnostics. So they recommended that diagnostics, first of all, be easy to use. They then need to identify a specific pathogen and then provide rapid results to impact clinical care. Because if results take many days or even weeks to result, often at that point, the results may no longer be relevant to that patient scenario. But beyond that, they should also provide some sort of resistance information about antimicrobial agents. And then they need to be effectively communicated to the clinician so that the information is clear and can be acted on immediately.
Thank you, Janie. Back to the case. Dr. Goldberg, you now have a little more information. You have a good perspective from a microbiologist. Walk us through your clinical decision-making to get to a diagnosis and a treatment plan.
Will do, Ben. And as we'll do for our audience today, we won't give the answer about the case, but we'll look forward to their input and discuss that. So based on this information, we have someone that has a new subjective complaint, an unremarkable exam, not clear that they have a past history, and we don't have any information about the local environment, the prevalence, for example, of sexually transmitted disease. So the practitioner has to make a decision. Do I empirically treat or not? And if not, waiting for definitive diagnostics. And then also what to include in your evaluation. Do you need to think about, for example, HIV or syphilis? So those are some of the questions that we think about when evaluating someone with this profile and this problem.
Very good. So with that, we have our first audience survey question. In this scenario, do you prefer empiric treatment or diagnostic test results driven treatment in your setting? And you can click your answer there, and we have 20% voted so far. They keep on coming in. So about half the people have voted so far. I think that's a big enough sample size. 93% are saying results driven treatment. Janie, Dr. Goldberg, what are your thoughts? Stephen, why don't you lead us off?
And again, I think it depends on the patient profile. I think based on this patient's profile, I would have opted for results-driven treatment.
Janie, what would be the case for empiric treatment? In what scenarios would empiric treatment make sense to you?
I think as a microbiologist, the best approach is informed by a few things. The patient's past history, how much information are they willing to share with you? Can you get a good idea of the risk factors? But then also the prevalence of sexually transmitted infections in the practice or in the community. And if the risk for an STI based on these 2 factors seems low and there are no symptoms, waiting for test results may prevent unnecessary antibiotic exposure. But if during the course of the patient history you find out that they may be at elevated risk, and that there's a high prevalence in the community, empiric treatment right then and there makes sense, especially if you're concerned about losing the patient to follow up.
Yeah, that loss to follow really kind of makes this complex in that scenario. All right, let's move to our next case. Dr. Goldberg, your next patient today is a 62-year-old female that presents with a fever. She complains of continued burning during urination. She does have a history of recurrent urinary tract infections and reports having received antibiotic treatment several times. She doesn't recall the name of the antibiotic that was prescribed previously. So what's your take upon seeing this patient, Dr. Goldberg?
And this is quite a common scenario. I begin with reminding us all that recurrent urinary tract infections are not a trivial matter, and approximately 10% of adults have some degree of kidney dysfunction. These infections can be really uncomfortable, and if untreated, can extend to more generalized infections, such as sepsis, a blood infection. During the summer, people could be more likely to be underhydrated, and that can be a risk factor for urinary tract infections, but not necessarily the cause. And when the body's dehydrated, it doesn't have enough fluids to flush bacteria out of the urethra, and bacteria can irritate the bladder and urethra, which can contribute to a UTI.
Yeah, so what I hear you saying, Stephen, is in a case like this, speed really matters. Janie, from a microbiology standpoint, she's talking about, antibiotic resistance and recurrent UTIs. How does that impact your thinking?
So we're aware of increasing rates to many classes of antibiotics, especially with urinary tract infections. We're likely concerned about resistance to Bactrim, also known as trimethoprim sulfa, which is very commonly used to treat urinary tract infections. So when we do a diagnostic test for this patient, having resistance information is going to be really critical to informing treatment planning.
Very good. Dr. Goldberg, the patient on clinical exam has a fever of 38C and is unable to provide a significant urine sample. What are your thoughts based on this information?
Well, Ben, to your previous comment, we really want to get it right. This is someone that's had recurrent urinary tract infections, and our microbiologist is advising us about resistance issues. We're really challenged. They're sick. I mean, they have a fever of 38 degrees, and they're unable to provide a sample. Now, I don't know if that's because their volume contracted or dehydrated or other, but I'm concerned about this patient, and I want to make sure I get it right. Empiric therapy in this patient's already failed. The optimal approach would be to wait for a diagnostic result to help inform selection of a specific antibiotic. But in this patient, I'm not so sure we can.
Urgency matters right here for sure. So Janie, what pathogens do we need to be most concerned about, and what are our options for a diagnostic tool?
With UTIs in older adults, they're more prone to antibiotic-resistant infections due to just a longer history of antibiotic exposure throughout their lifetime. We're more likely to see complex drug-resistant infections or even polymicrobial infections compared to perhaps younger adults. When we think about diagnostic tests available, urinalysis is going to be a great starting point in the clinic. But there is limitations to these. The nitrites result from a urinalysis is highly specific for UTI, but it lacks sensitivity as not all UTI pathogens convert nitrates to nitrites. Beyond that, the leukocytes results are much more sensitive for UTIs, but they lack specificity as there are multiple conditions that can cause a positive leukocyte result. After the urinalysis, a clinician may opt to do a culture, and these will offer very specific results. But these can take 3 to 5 days to provide a final result and often require a significant sample volume and specific specimen collection because you will want to get a very nice quality clean catch to avoid contaminants as a result for the test. In this situation, PCR might be a valuable tool because the test only requires a small sample volume. So about 1 milliliter of urine or less is going to be able to get an answer for this patient. And it's also going to be able to identify resistance genes present in that sample. It doesn't require pathogen growth, so results can often be finalized in 24 hours or less, helping to get the patient a faster answer.
Very good. So Dr. Goldberg, walk us through your decision making to get to a treatment plan for this patient, please.
Again, I think they're sick, and hearing what Jeannie has shared, getting an insight that has pathogen-specific information and also anti-infective phenotypic resistance information is optimal because they're sick, they've had recurrent infections, and they're not recalling what they've used in the past. But based on physical exam, noting the fever, their history, I would be inclined to prescribe empirically given these classic symptoms and what I feel is a patient at risk for more generalized infection. Now, to make an anti-infective choice, providers are going to need to be aware of the antibiotic resistance patterns in their community. And so we would likely empirically treat, get the diagnostic insight, and next morning confirm we're on the right track.
So with that, we have our next audience survey question. What is your approach with patients unable to provide a significant urine sample for testing? A, treat empirically regardless of symptoms. B, treat empirically only if classic symptoms such as frequency, urgency, dysuria are present. C, treat empirically only if patient has other risk factors such as history of recurrent infections, active pregnancy or such. And D, I do not use empiric treatment. So send in your answers real quick, have a quick discussion on that. So treat empirically only if patient has other risk factors and treat empirically if classic symptoms occur seem to be the two biggest. Dr. Goldberg, walk us through your thoughts on those two options.
These are not easy decisions, and it really needs to be contextualized to the patient, the setting, and other considerations, as Dr. French has shared. I can understand why we have divergence of opinion in terms of approach on this question.
I think it's really about the specific patient scenario. Waiting until you get test results back to make a treatment decision means that your patient only ever takes an antibiotic that's going to be effective for their symptoms. However, there is reason to treat empirically if the patient is at high risk for complications, or if they are a young female patient most likely to just have a classic E. coli UTI and you can provide them relief immediately with an empiric treatment. So I think it depends on the setting and the risk factors involved.
It's always one of the hard things with these cases is you have a little bit of information. You don't get to put your eyes and hands on the patient to get more. Thank you all for walking us through that case. With that, we have our third case. This is a 7-year-old that presents with the complaint of excessive dandruff and itchy scalp. The condition comes and goes, no relevant medical history. The young boy loves video games and goes outside infrequently, especially during the heat of the summer, refuses to bathe, and lives in his bedroom with 3 other siblings. The home does not have air conditioning, which is really hard this time of year. Dr. Goldberg, what are your thoughts here?
While cases like this aren't necessarily common complaints in an urgent center setting, they can provide some diagnostic challenges. There are several conditions that can cause an itchy scalp: dandruff, seborrheic dermatitis, psoriasis, eczema, and you also have to consider head lice and scabies, and certainly Tinea capitis, a fungal infection. Now, if you've been practicing many years, you likely have been able to see individual examples of each condition, and you can make a clinical diagnosis. But if you're earlier in your career, and even for me today, it still can sometimes be challenging. So if you're not confident on your empiric diagnosis, a diagnostic test can be helpful.
So when the patient comes in, Dr. Goldberg, you see small patches of alopecia, some dry scaly rashes, and some patches of redness. Any additional thoughts here? We're kind of taking this?
We frankly gave some features here that suggested a single diagnosis in those that I listed. This child is a setup for that circumstance because of some of the features we mentioned. Not getting outside to get sunlight or drying of skin, disinclined to bathe, so puts them at risk for certain types of infection. Crowded conditions and lack of air conditioning also contribute to that case.
Thank you. So Janie, walk us through from a microbiologist perspective, what are you thinking and how would you proceed to diagnose this patient?
If we're concerned about Tinea capitis, there are 2 primary fungal species causing these cases. These would be Trichophyton tonsurans and Microsporum canis. Really, when we think about diagnostic techniques available, we want to be able to diagnose these 2 particular fungal species. And while differentiating them is not strictly necessary for treatment, their differences do make them challenging to diagnose. And it's often recommended to get a positive test result for tinea cases because there may be non-infectious causes that result in similar symptoms, and systemic antifungals aren't always required. Because systemic antifungal treatments can last 4 to 8 weeks, adherence can be low. So if treatment fails and you don't have a diagnostic test result, it's hard to know, is it because there was low adherence to the treatment, or is it because you need to consider an alternate diagnosis? So a diagnostic test result can help you be definitive about whether or not it's an infectious cause. When we think about the diagnostic techniques available, culture can be an option, but it may take several days to weeks to get a result depending on how fast the fungal species is growing. There are also some in-house testing options available. A provider could do a KOH prep, but these often lack sensitivity for these fungal species. A clinic may have a Woods lamp available in the clinic, which is just a UV light. And this can be helpful for identifying microsporum species because microsporum fluoresces under UV light, but trichophyton does not. So while the Woods lamp would allow you to rule out microsporum, it wouldn't allow you to rule out trichophyton infection. Another option then would maybe be the use of PCR, which has the advantage of being rapid and capable of identifying both fungal species to get an answer for the patient.
So Janie, kind of what I hear you saying there is clinically actionable can be that treat, don't treat decision being as important as I need to write a prescription for a patient like this. Very interesting. So Dr. Goldberg, walk us through your medical decision-making and treatment plan for this patient, please.
We have to decide if this is something that we think is contained to the superficial scalp, or we think there's risk of a more generalized infection. If we think there's a more generalized infection risk, then down the road we might have to think about oral antifungals. If we think it's confined to the scalp, we likely could get some success with tar compound shampoos and etc. Now, going back, the differential is kind of broad, but based on what the clinical situation set up, this patient was more likely to be having a tinea diagnosis than another diagnosis. So based on exam, if it looked constrained, I would be inclined to get a sample for definitive diagnosis to make sure if I needed to escalate treatment, I'd have a match between the antifungal and the pathogen. But if it's confined and limited, I'd likely start with a topical antifungal shampoo while waiting for confirmation of a specific infectious agent.
Thank you. So with that, we have our next audience survey question. In this scenario, what would you use to decide if this is tinea? No test, I'd treat empirically. Culture, KOH prep or Woods lamp, or clinically actionable PCR. And our results are coming in. We have a smattering of several answers so far. Pretty interesting. All right, so Janie, Stephen, y'all are seeing the results here. We kind of have a mixed bag of clinical actionable PCR right at 38%, then 25% for the KOH prep, Woods lamp, or no empiric treatment. Stephen, what are your thoughts on those results?
I think people have training and ongoing education on different approach to different clinical problems. I also think they have different resources within their practice care setting, different availability or not of different types of point of care testing. So I think as Janie outlined, several of these point of care options have utility with some limitations or some benefits. So I think it's all reasonable. In the setting where I work in, we don't have access to KOH prep or Woods lamp. And again, if you have high confidence in your ability to differentiate among several different itchy type conditions, then empiric treatment might be reasonable. But if there's doubt, especially with concern of risk to follow-up, then getting a diagnosis specific would be really helpful.
Thank you. Jane, anything to add?
Exactly like Dr. Goldberg said, if you've seen cases like this and you're comfortable differentiating between different causes of these patient symptoms, it may not be necessary to test unless there's treatment failure and you're concerned that maybe the initial diagnosis was incorrect. But beyond that, it becomes about what tests have you used before and are comfortable using and what's available in your clinic.
Thank you. Your fourth case today has a chief complaint of painful lesions on the thigh and buttock area It's a 25-year-old male who's sexually active. Based on that quick summary, anything jump out at you that you're thinking of?
When I actually had this case, and the patient came to me on follow-up after the patient and their partner had been told that they had a first episode of HSV2 or genital herpes. And that decision, that communication was based strictly on empiric evaluation of this blistering lesion. What I would begin to say is that having seen different types of blistering lesions and knowing that genital herpes or HSV2, not every time, but consistently has a genital manifestation, this patient is presenting with painful lesions on the thigh and buttocks, but did not have any genital involvement. That occurrence caused me to question the initial diagnosis of HSV2 or genital herpes.
Very interesting. Janie, the clinical exam shows it's on the left buttock area, anterior thigh, finds rash with a dermatome pattern, no genital involvement. I'm sorry, Stephen, anything to add based on that information?
Well, there were certain features. Again, Ben, the first, there wasn't genital involvement. The involvement of the buttocks wasn't necessarily helpful to help me differentiate among different types of blistering lesions. But the anterior thigh lesion following a dermatome pattern was pretty pathognomonic for a blistering type of lesion, specifically a varicella infection, a Coxsackie virus, or in an adult, it can be called shingles.
Janie, Dr. Goldberg mentioned a couple pathogens he's thinking of. What are the other pathogens to be concerned about and the thought process on these types of infections?
So a blistering lesion around the groin might suggest that sexually transmitted infections should be included in the differential. But as we see in this case, there's no genital involvement for this patient. So it's likely not a sexually transmitted infection. But there are also plenty of other non-sexually transmitted pathogens that can cause blistering lesions. As Dr. Goldberg just mentioned, varicella zoster virus, Vibrio vulnificus, enterovirus, just to name a few. And shingles tends to be more common in the spring or summer, actually typically thought to be due to increased UV exposure. This increased UV exposure reactivates the virus and leads to those painful shingles outbreaks that can be observed. But similarly, it could be non-infectious, like poison ivy, which is going to also be more common in the summer because people change their behaviors seasonally. So in the summer, people are spending more time outside, they're gardening, they're hiking, and there's just increased risk of exposure. We want to be able to rule out infections. And when we think about diagnostic techniques available, serology may be an option for infections like HSV, or if there are concerns about the lesions potentially being syphilis, RPR could be performed. But PCR might also be an option that's going to be really comprehensive because it's going to allow you to test for viral infections and potential bacterial infections as well. So really cover all the pathogens most relevant to blistering lesions.
This is a great case because you have that element of clinical confusion. Is it pathogenic? Is it a non-pathogen? Is it an STI? Is it something from the environment? And urgency matters because I'm sure these people are concerned. So Dr. Goldberg, this was your case. Walk us through what you did for this patient.
The first thing I did was sit down and have a conversation with the couple. And you want to be respectful of your colleague who did the initial evaluation. Things could have clinically changed. There could have been different information conveyed. So I really wanted to start from scratch. And I wanted to interview the patient's history, understand any self-awareness of childhood infections, immunizations, recollection of an episode of chickenpox, a varicella infection, certainly past history of sexually transmitted disease. Had the couple, either of them had a herpes genital infection in the past, and if either previously had a history of a shingles episode.
Thank you. Based off of that, we'll go to our next audience response question. In this scenario, would you have done STI testing? A, yes, for genital lesion pathogens. No, I'd only test for blistering lesions that are not classified as STIs. And so far we have a 50-50 split, kind of shifting back and forth. So we have about a 2/3, 1/3 split. Dr. Goldberg, what are your thoughts?
I think testing for genital lesion pathogens made sense. And at least in this couple and with this individual, I had high clinical confidence that we were not dealing with a HSV2 or genital herpes infection. And based on the clinical pattern, it appeared to be more likely a varicella virus or shingles infection. And because the patient still was within a narrow window of when an antiviral therapy could be helpful, we empirically prescribed vanciclovir at the appropriate dose for a shingles outbreak. One would follow up with, ideally, a next morning PCR result, or if not, in a little bit of delay, serology or other.
Janie, any other thoughts on this case?
I would just echo what Dr. Goldberg said, that if there's no genital involvement, it may not be necessary to test for genital lesion pathogens, but at the point that he had seen this patient where they had been empirically diagnosed with HSV2, it actually may give the patient relief that it's not HSV2. So being able to rule that out could be really comforting for the patient in this scenario.
Very good. Well, thank you all both for your insights today. Dr. Goldberg, any final thoughts that you want to share with our audience before we get to questions?
Well, 3 comments, Ben. It's always fun to have a microbiologist with you to offer the larger context when evaluating patients, but we don't have that opportunity regularly, right? So we've got humility about that. The second is infectious disease are a common problem in the urgent care setting. I see it regularly. I saw it yesterday in the clinic. And then finally, you really want to get it right, and getting it right involves knowing what types of infections you're more likely to see in the summer versus other time during the year.
Eliminating that clinical confusion and getting the patient comfortable with what you're doing seems like it's really important. Jenny, what about from a microbiologist perspective? Anything to close on?
People are generally really familiar with the seasonality of respiratory infections occurring at higher rates in the fall and winter. But there are also considerations for summertime infections, because environmental changes like increased UV exposure causing higher rates of shingles episodes, or increased temperature and humidity increasing fungal infection rates are common. And there can also be behavioral changes. People are going to go to community pools where there may be exposure to waterborne illnesses, or there may be increased exposure to environmental toxins like poison ivy. Thinking about the risk factors of different infections and the prevalence in the community will be helpful in diagnosing some of these summertime infections.
So with that, we'll open it up for questions. We do have one question that has already been submitted. Dr. Goldberg, I'll send this one to you. What do you do in the scenario where the patient wants an antibiotic right now, no matter what, and you want to take that watchful waiting approach? How do you deal with that scenario?
That is very hard, and I don't have a strategy that I've experienced works every time. So I'll begin with first a statement of humility. I think that the approach to dealing with people is to really take time in the encounter, to not be rushed, to listen, so they are feeling highly engaged by the practitioner and the encounter experience. If they feel rushed, you're done. So giving attention, listening, thoughtful history taking, appropriate exam, and then explaining your rationale for what you want to do. I feel an obligation about inappropriate antibiotic prescribing, so I'm willing to take on that conflict. We're well aware that in outpatient infectious disease, overprescribing of antibiotic overall could be as high as 30%, and for respiratory conditions, as high as 50%. And if we continue on this national trend, morbidity and mortality related to antibiotic resistance worldwide could be more problematic than cancer. So I feel an obligation in each one of the encounters that if I don't think an antibiotic will be appropriate to the patient, I try not to provide it. And if you have in your armamentarium, for example, PCR testing with next morning results, usually you can negotiate with the patient and tell them that they will be getting a very specific description of the pathogen, as well as our description, phenotypic resistance, right? to really let them know we're interested in them getting better faster and being precise in the diagnosis. So that's how I approach it, but I recognize it's absolutely not an easy decision or process.
Never is. Janie, we have another question here that I'll send to you. Right now, there's a lot of different point of care testing options, whether it be something as simple as a strep test or other point of care options. And then you have rapid PCR. Clearly, speed matters with infectious disease diagnosis. How would you advise clinicians to kind of juggle those different options and use the right diagnostic technique for the right patient scenarios?
Yeah, absolutely. We get this question all the time. Speed is almost always a critical factor in deciding what diagnostic technique to use. So often I recommend that if providers have, rapid antigen tests available in the clinic, those are going to get their patients the answers they need the fastest. So those are often a great place to start. However, there are limitations with tests like those as they're incredibly specific, but they often lack sensitivity. If those are negative, then it may make sense to send out for additional testing. So really, I think there's a combination approach to be used with point of care tests and PCR.
Thank you very much. With that, we will end. Thank you for joining us for this Urgent Care Rounds brought to you by the Urgent Care Association Solutions webinar and HealthTrackRx.